the Medical AI Podcast.
Hello and welcome to the Medical AI Podcast, a 30-minute thrill ride of big ideas. I'm Dr. Felix Beecher and I discuss with scientists, innovators and philosophers. Heart arrhythmias, or irregular heartbeats, can indicate very serious and very common health problems. These include stroke, heart failure, and cardiac arrest. In today's episode, we will discuss how AI approaches are helping to transform cardiology by detection of heart arrhythmias. And with me to discuss this is Stuart Long, CEO of infobionic.ai. Stuart, a huge welcome to the podcast.
Thank you very much. It's great to be here. Appreciate the time.
Thank you. All right. Well, look, could you just introduce yourself to the listeners, Stuart?
I'd be happy to. My name is Stuart Long, and I am the CEO of infobionic.ai, which is a company that does remote cardiac monitoring, and we diagnose arrhythmias.
Straight off the bat, Stuart, I have to tell you, about a year ago, no, more than that, I had an experience myself of heart arrhythmias, and it was pretty scary, but it turned out to be not life-threatening, touch wood. How about you? Have you ever had heart arrhythmias? And this goes to the commonness of this kind of symptom.
Yes, I have, in fact. I've had arrhythmias for quite some time, and I always attributed it to probably too much caffeine many years ago. And it turned out that I had an arrhythmia that it wasn't until it got a little bit more uncomfortable in terms of the symptoms that I felt before I was able to be in a position to put myself on a cardiac monitor and have a cardiologist on the other end of that line confirm that it indeed was something that we needed to really pay attention to. So yes, I have.
Okay, but you look in the pink of health these days, Stuart. I'm glad to say, am I right?
It's one of the benefits of early detection, which we'll probably get into more.
Okay, good. All right, so let's start with a basic question. What problem are you trying to solve here, Stuart?
So we are solving for a couple of problems, I think, that are key. One is a high-quality detection of arrhythmias that are remote, not in the hospital while you're laying there very still, but when you're in your home doing your daily activities, you may have had some kind of symptoms, whether it's a little flutter or some dizziness, and you saw your doctor. They might have referred you to a cardiologist, and they said, well, let's put a device on and see if we can't catch this. So that's what we do. We have designed a system that does one kind of monitoring that is a very high quality type of monitoring, similar to what you would get if you were actually in the hospital. And we do a really good job of wading through all of the motion artifact that's present when you're moving around all the time. So that was one of the things that we solved for, is we wanted to overcome a lot of the barriers that we've seen historically as just poor quality. And that leads to what's called our false positives. So a massive reduction in false positives, getting to, pun intended, really the heart of the matter much more quickly. And the second part of that puzzle that we wanted to solve was not only bring the quality, but we wanted to decrease the time it takes to get that information to a cardiologist or a clinician who's responsible for that test. So we've been able to improve quality, reduce the false positives, and we've been able to speed up the time that a physician can get that information. And that's a great reduction in time for diagnosis, which more importantly speeds up the time to an intervention so that the doctors can treat that, whether that's go home and sleep better, change your diet, or take medication, or I need to get you into the cath lab or the OR.
So to be clear then, you're talking about a new type of analytical tools rather than anything to do with hardware, correct?
Well, it's actually all of the above, and I know that's kind of a broad statement. When I say all of the above, there's analytical tools that are definitely key, but I think the primary basis from which all of it stems, and it's a classic computer analogy where it's garbage in, garbage out. So if you're typing incorrectly or trying to import data that's not formatted correctly, the results are going to be, poor quality. And it's no different than if you're acquiring a heart signal from your body, and the signal that you acquire and how you process that signal is of lower quality. You're not going to have the same kind of results. So it starts at the signal processing level, which is the precursor for all things biometric data. When you acquire that information from the human body, you have to send it through some signal processing. And we've been developing the R&D group that part of infobionic.ai has been doing this for over 30 years, back to some of the earliest devices. So we start with world-class signal processing, and on top of that, we start to build the analytical tools. Both mathematical analytical tools, technical analytical tools, and then now AI analytical tools.
Okay, so let's lay some groundwork here. What is a heart arrhythmia, and why is it significant to health?
So easy way to understand it is your heart has two sides. It has an electrical side and a plumbing side, just like your house. And they're two independent systems, but at least in the heart, they rely on each other heavily. So an arrhythmia is some form of it's maybe a rough word, but it's a deformity in terms of the electrical side, so that one of the electrical paths becomes either malformed or it just has a hiccup along the signal. Hiccup can be your heart skipping, and then a malformation can be an actual arrhythmia that is present sometimes only or constantly present. So it's really a change in the electrical side of your heart and the way that electrical system communicates its information. It's supposed to do it a very particular way all the time, 100% of the time. It can have changes where it doesn't do that, less than 1% of the time. And those are generally, a lot of people don't even know that they have those, where it can then, when it represents a greater percentage, you start to feel those, and even a greater percentage is when you really need treatment.
Now, we know, of course, that heart disease, and not just heart disease, stroke as well, they're major killers, especially in the West. Could you just take us through the connection between arrhythmia and those kinds of issue?
Yeah, stroke is probably the most common and probably one of the most expensive results of an arrhythmia. It's the atrial fibrillation is the arrhythmia that leads to that. And atrial fibrillation is very much what it says. So your atria, which is the top part of your heart, you have two chambers on the top and two ventricles on the bottom. And if the chamber on the top fibrillates, meaning it kind of quivers, right? It doesn't actually pump like it should. The blood won't move through quickly enough, and it will kind of circulate. And we know that with anything highly viscous, it can coagulate, which is exactly what is happening. Your blood tends to coagulate in an environment where it's not moving the way that it should, and that can cause buildup of plaque in the heart, and that plaque can dislodge at any given time. And in the atrium, it most often goes directly to the brain, and that's what causes the stroke, is a piece of plaque from your atria, from the atrial fibrillation arrhythmia, goes up into your brain, does a clog in your brain, and that's effectively what a stroke is. And so there's a lot of varying degrees of what those strokes can have. Some are highly recoverable, and some are non-recoverable. So that's a good example, I think, of what an arrhythmia is. And it affects both sides of the heart, your left and right, and top and bottom.
Now, stroke is a big killer, but so is heart disease. Could you just take us through the connection between arrhythmia and heart disease as well?
Sure. Heart disease is, most often thought about as a plumbing problem. Your plumbing gets clogged and the blood can't get to the muscles, so the muscles get starved and they are unable to contract, and that causes a heart attack. And so it's very much a plumbing problem. Oftentimes it can be a result of the electrical side of the heart, an arrhythmia, not doing what it's supposed to be doing, or it could be the inverse. The health of the heart, through the foods that we eat and hereditary disposition, can cause the buildup of plaque in the heart. And we've seen this even in healthy people, athletes, marathon runners, et cetera. The hereditary component can certainly have an effect there. So the buildup of plaque in the veins, the dysfunction of a muscle not beating correctly. So you may not have buildup in your veins, but you might have one wall of your heart that doesn't beat correctly. And all of those are elements of heart disease. And so it can be a combination of electrical and plumbing. It can start with plumbing and become electrical, and it can and do the inverse. It really becomes pretty complex, and that's why having a heart monitor try to help look at the heart, try to determine the origins, of the disease and potentially even the severity of it or the lack of severity is critical. And that's the business that we're in, is trying to find that sooner than later.
Now, a lot of people have been to the doctor and had an ECG, and so they're more or less familiar with the kind of output that you get from an ECG, which is kind of a straight line with regular blips in, corresponding to heartbeats. Now, how might that time series data change in somebody with arrhythmia, and also how do those changes relate to the kinds of problems we've discussed, like heart disease and stroke?
Yeah. So the squiggly lines, I'll call them, they're representative of the different pathways in your heart, really looking at them in different views. Imagine if you had a slice of bread and you cut it in half, you had 2 loaves instead of 1, or now you can take those 2 loaves, cut them down the middle, you have 4, you can cut them on an axis, etc. So the typical ECG that you get in the hospital is what's called a 12-lead ECG. It's the gold standard. It has all of the axis and electrodes to be able to see on all axes through your heart. So you can get a good look at all of the electrical systems all the way through your heart. And there's even some indication of the heart function and whether a wall might be affected when you have that many leads and that many channels. So oftentimes, though, that test itself is roughly 10 to 15 seconds. So if you've experienced an arrhythmia and it's not present all the time, then it may be difficult for the physician or the clinicians who are looking at that to determine if in fact there's anything wrong. So that's one of the downsides, is it's really more of a spot check, where in heart disease, if you've had an actual heart attack and you've gone to the hospital and they do this 12-lead ECG, and you may not have any electrical activity related to that yet, the ECG has changed just enough to tell the clinicians looking at that, oh, you did in fact have a heart attack. So the way those lines change, whether it's in their height or their distance spread apart, that can give some great indicators on that particular exam. Where it becomes more important to watch the arrhythmias is if we are in an arrhythmia that is very frequent or all the time, like atrial fibrillation. One of the things that you see is one of the little waves on that line disappears. But the problem with it is your heart jiggles, and that line that disappears looks like it's a jiggle normally when it's normal. So when you have a bunch of jiggles and that line disappears, it becomes even harder to detect. So even though it's one of the most common arrhythmias. So that's why there's a lot of focus on atrial fibrillation. So then you get into your heart actually stopping, what they call heart blocks, or you get into tachycardia, which is your heart beating very, very fast. You get into ventricular tachycardia, super ventricular tachycardia. Fibrillation for your ventricles is probably one of the most severe arrhythmias you can have. So all of those change those squiggly lines, and depending on the severity of the arrhythmia, the age of the arrhythmia, then the physicians or clinicians are able to look at those lines, and in a system that we've captured more than 10 or 15 seconds, we can capture up to 30 days or longer if needed, where now the tools are in AI, we can isolate those areas where it's not normal and point those out to clinicians much more easily and with a much higher degree of accuracy than we've ever been able to do in the past, so that they can sift through a lot of data much quicker and get to the point much faster.
Now, I would imagine that with the ECG, what you have is a very, very rich set of data where, because you have 15 leads potentially, and you have a certain period of time that those data are sampled from. And I'm guessing, without being a cardiologist, that cardiologists, being very busy people, might kind of glance at it and give an impression, but actually there's lots of hidden data or hidden information in the data set that maybe an AI system can pick out, but maybe a human cardiologist wouldn't even see or wouldn't pay attention to. Is that true?
Most clinicians are able to pick out most everything. There are new technologies that we're developing and will implement, and some have already been FDA approved, where we can pick off things that the human eye just can't see. But I would say that the ECG is incredibly rich, richer than we ever imagined it to be, and its potential to be transformative, I think, when we've reached a point in healthcare where we now have kind of what we call converging lines of correlation, other conditions, and so where you might have where you might normally have gotten an ultrasound to detect something, or a blood test to detect something, we're now training the AI to be able to detect these in an ECG in advance of getting an ultrasound, or in advance of getting a blood test, to say this particular part of your blood is either high or low potassium, or your proteins are off, or your the heart, the amount of blood your heart is supposed to pump is below a normal value, and so we need to take more invasive action, or there's the potential for it to be that. So more detecting hidden diseases that haven't become symptomatic, and that's, I think, one of the big keys of the remote monitoring technology, is that now we're monitoring patients 24/7, not a spot check, because you have about 100,000, on average, about 100,000 heartbeats per day per person, and if you wear a monitor for 10 days, that's a whole bunch of heartbeats, right? And so being able to assess that information on a much broader scale, run some AI that's been trained to detect this latent disease or hidden disease, and prompt or alert on these things in a almost a near real-time way, I think is what will really kind of change the landscape of at least cardiac monitoring. But the idea that we can just do the basic nuts and bolts of arrhythmia detection and diagnosis now, with all of these heartbeats remotely, with a high quality way, reduce false positives, get to the actual treatment faster, has really been the big first hurdle that we've been able to cross and achieve. And we're fast moving on now with AI, both for clinical efficiency, right? That doctor or that clinician looking at a much larger set of data with fewer data points to point them in the right direction with much higher accuracy, to the clinical side, which is detecting the latent disease or other types of things that you would normally need another test for, which is additional time, cost, and energy on
right. I mean, I think this is one of the most interesting features of these kinds of AI systems, right? That they could throw information up that you just never really even imagined could be got from an ECG trace.
Yeah, it's crazy. When I first saw some of the work that we're now doing, that we're involved in, but when it was being done in the research level, I was like, it was hard to believe. I've been in cardiology and ECGs for 30 years, and it was just amazing to see the evolution of where it is today.
Now, so you've developed a very nice system for arrhythmia detection using AI systems, and presumably there is some kind of benefit to be had from that. So could you just explain what the limitations of the status quo is, or are, and
Sure.
how your kind of systems improve on that?
Yeah. So the market, I mean, the ECG and what's called Holter monitoring, it's a 2-day test. It's been around since the 60s. And if you can even Google Dr. Holter, the original pictures he's got literally the size of a machine on his back. And so, the adage, it's come a long way, baby, rings very, very true. But even just 5 years ago, a lot of the systems were being worn. They would record on the device. And this is still true for some of the tests that are in market, where they record on the device. You wear it for up to 30 days. You mail it out to the home. You wear it. You can push a button if you're symptomatic, or some even let you log the event in a diary. Then you mail it back, and you get the doctor gets a result maybe a week or two later. So you're probably a month and a half or in close to 2 months by the time you saw your doctor. He decided he needed it, got it mailed out, and you get your results. Where and then there was multiple different kinds of tests for different types of arrhythmias, and then based on insurance requirements, you sometimes had to do one test before you could do another, which meant patients had to drive in and out and change devices. So it was a bit of a quagmire. And fast forward today, where I think we were one of the first that came along with a continuous streaming cloud-based system. It wasn't, cloud-based systems weren't really, a new thing 5 years ago, but in this particular segment of cardiology, it was. and we really sped up the delivery of information. We do it, do it all on one device, and that's where the market really has evolved. So it's really kind of it's the standard now. So anything that comes to market, isn't cloud-based. Most everybody's trying to stream the data. They're trying to do it as most efficient way possible. So I think you can't get a bad cardiac monitor in today's world. The technology has evolved very rapidly just over the last 5, 6, 7 years, and that's a great thing for patients. So the benefit, I think, today over traditional systems is the speed at which data can be delivered, the less complexity for the patient, the easier it is for physicians, clinicians to get and sift through piles of data. They don't have to wait. They can get their results, as it's happening. And it's become very efficient. So all of that in combination is a huge benefit to the patient. It's an enormous benefit to the clinicians, and it's a great benefit to the health systems that are providing care, because it reduces the burden that they've normally had to carry with just the infrastructure and the resources to manage that process. And then at the end of the day, the insurance companies, we can't forget about them. It's better for them because we're finding these conditions earlier and earlier, and we're able to implement more cost advantageous treatment plans for patients so that they can live a higher quality of life, and we can catch these diseases sooner. We're on a fast track to expedite that, I think, exponentially, in terms of detection of things that we hadn't been detecting before. And so I think we're just at a next step in the next evolution. But the last 5 years have been really, really great to see, and I think we're happy that we got to be part of that.
Now, lots of people have Apple Watches, and I think I'm right. I don't have one, but I think all Apple Watches come with some kind of ECG type of monitor. Could you just compare your product to that kind of?
So there. Easy way to do it is there's really I'll talk about 3 buckets of or classes of devices. So there's when you look at the consumer side of the equation, you look at the patient diagnostic, where you're identifying and you're diagnosing segment, and then you look at the intervention, which is after you've diagnosed. So those are kind of the 3 buckets where devices live. On the consumer side, we've forever, I used to do marathons and races and stuff, and I had a chest strap and I had my ECG in my watch, and those have been around for a really long time, and that's the athletes today, they demand a higher level of sophistication and quality, which is great. But that market really bifurcated into kind of a consumer grade versus medical grade, and now what you see is Apple Watch, Google Fitbit, and many others in that category, where they're on the screening side, but they're FDA approved in that they are certified by the government to say that the data they collect has been rigorously tested and passes certain criteria for safety and quality. And the Apple Watch and anything like it is a kind of device that would say, I think you might have a problem. Go check, go have somebody take a look at this. And in many cases, you can use these devices to identify something, send it to your doctor, and they'll say, yeah, that looks like it might be something. Come see me, and we'll put a different monitor on you that actually does diagnosis. And that's where devices like my company does. We're in that bucket of diagnosis, and it's our job to diagnose with as high as accuracy as possible, so that the doctor can identify the problem, without error, and then do treatment based on that. And then the treatment, when you get into devices on the therapy or the intervention side, are devices that generally get implanted into the body, like a pacemaker, a defibrillator, or something like that.
Okay, well, let's explore accuracy a little bit more. Has research been done on head-to-head comparisons between a human cardiologist and this kind of system?
They have. There's been a few. We've seen. It seems to track very closely with when you look at what ChatGPT is doing, where they kind of started out as an elementary student, a high school student, a college student. Now their latest models are at a PhD level, a kind of an entry level PhD model if you read enough on it. But the data that we've seen is the AI can be almost as good as the cardiologist in terms of finding things, all of the known arrhythmias. When we get into more complex things, we see some of the new AI performing quite well. So, but I'd be hesitant to say, even at this stage, that AI outperforms a human because of the nuance and the context of other factors that are involved, right? So, it does a really good job of being an assistant to a physician or to clinicians. We have many experts on staff. We work with the Mayo Clinic. Those are, I hold them in high regard in terms of their qualifications. And that, I would say I would put them ahead of the AI in terms of rating. But there will be a time where, and they've already published some AI algorithms, and we work with Mayo Clinic very closely, and we'll be implementing some of that technology in the not too distant future, where the clinician or even the naked eye it doesn't have the ability to detect things. So I think we'll start to see the AI being better than human capabilities, within the next 12 to 24 months.
All right. So Stuart, could you talk a little bit about where your company is and where the market is? Like, for example, if somebody in the United States or perhaps in Europe goes to a cardiologist, how likely are they to be assessed by an AI system like yours?
So I think it's especially in the U.S. And to a high degree, I think abroad, that you're going to see a cardiologist and they're going to put a monitor on you of some kind that is using some sort of artificial intelligence or algorithms that were designed. And algorithms, these have been around for quite some time. They're mathematical algorithms, not necessarily machine learned in terms of what we define artificial intelligence as. And that's one of the great things about the adoption rate, because I was in the insulin dosing space, endocrinology, and it was very difficult to get physicians to trust the AI or the math that we were using at the time. And in terms of cardiology, the algorithms have been running on the devices or the math, call it, for decades, and they're used to the system giving feedback. So there's a high degree of adoption, and I think that helps answer your question, in that it's high probability they put a device on you, and it's high probability that most of the systems that are being developed today are using some AI. A lot of the AI that's being used is mostly for workflow efficiency, trying to make their staff more efficient so that they can reduce the errors that humans make, which bodes well for the patients. But we're only starting to see AI on the clinical side to detect some of these latent diseases to a larger extent. And we've been using it since inception. So we go back to 2015 using machine learning. We have submitted and had FDA approval. These are not dynamic models or algorithms that are being run. You have to submit them to the FDA, get approved, and they're static. So, but we have seen, one of our first models we deployed was to help improve the false positive rates on atrial fibrillation. And when we did that, we were able to create. We have a system that uses 3 squiggly lines. We call it a 2-channel, 3-electrode, 3-lead system, and we were able to create a 6-lead system out of those 3 wires, using this algorithm. And what that did for us was it helped us reduce the noise, use kind of almost like some Bose noise cancellation headphones, very similar to that. And it reduced the false positive rates by almost up to 85%. So we saw that in 2017 or so. And so we're confident, I think, maybe to answer your question, that if it's, I don't know what percentage of the population is getting AI today, but there's going to be no doubt about it, within the next 3 to 4 years, you won't be able to get a cardiac monitor without some kind of both clinical workflow or clinical type AI.
I have to ask you, Stuart, at the beginning you were talking about drinking too much coffee, and I've got into the habit of drinking heroic amounts of coffee, and now I'm starting to worry that might not be such a great idea. Is there really a relationship between coffee drinking and arrhythmias and other heart problems?
Well, my wife definitely thinks there is. I'm a coffee lover, so I still refuse to believe it. However, I do think there can be some. I think I think too much of anything is not healthy. I know that my arrhythmia, now that I've been seen by experts, was born out of the kind of exercise that I was doing, and so it was more long distance stuff for extended periods of time with too high of a heart rate, which caused my atrium to enlarge. And after a while, they don't go back to normal size, which is how my arrhythmia actually started. So, and it had nothing to do with caffeine, but I think caffeine can exacerbate it and bring it about because I can induce my arrhythmia if I get on a treadmill and get a stress test. Like they can definitely turn it on. So I think anything in moderation, caffeine especially. So, but you don't have to stop drinking coffee. That's for sure.
Okay. Last question, Stuart. Ignoring cardiology AI, what is your favorite current example of medical AI that's got nothing to do with your area?
Well, I'm completely fascinated by the idea of explainable AI, and it goes along the lines of trust, right? So one of the biggest hurdles that AI has, even in the generative AI, when I say generative, it's with chat GPTs and things like that, is being able to trust the data, right? So we have meeting notes for AI, and it's almost, you can rely on it to be unreliable, right? And so when it comes to medical AI, physicians are still weary, right? And so, it certainly isn't going to take the place of anybody's job. I think it'll, certainly take the place of people's jobs that don't use AI. But explainable AI is a kind of AI that is explainable very in layman's terms. In that, I'll give you an example. So, for example, identifying cancer, say in breast tissue, with mammograms and things like that's been around for a while. And now there's new AI that can detect the risk of cardiovascular disease through mammograms and other kind of CAT scans and things of this nature. However, depending on the density of the tissue, which can be notoriously difficult, especially in breast imaging, but even in your body and in different types of body types, the AI now has the ability to almost police itself. So it can say, I have 100% confidence that this type of cancer was identified and for the following reasons, or I have a 70% confidence rate because the tissue density was measured at this level and my abilities aren't capable of doing that. And so it allows the clinicians to lean in or lean away from what they're doing at the desk, and it builds trust. And so I think we're still early in that, but I think it's going to be probably the most promising thing for the adoption or more widespread use of AI in healthcare is when the AI can be trusted by the clinicians with a high degree of accuracy. And right now we rely on an algorithm to get approved. We do research studies and it has a certain value, in terms of all the metrics that, it gets measured by and gets approved by the FDA. But we're not in a world where AI is making decisions that are not approved, where it's doing it on the fly. And I think explainable AI will be a gateway or a window for us to do that. And I think that's where the real benefit will come. So that's probably what's got me most excited about where we're going.
Right. Okay. Well, look, Stuart, I think you've given a magnificent account of this obviously very interesting and obviously very important area. So thank you so much. It's been great to have you on.
It's been a pleasure. Thanks for having me.
Bye-bye. Thanks for listening. Ping me on LinkedIn if you have any ideas on new subjects or guests.